Hello, and welcome to starting Unit 3 of Transitioning to Value-Based Care with this lecture on Financial Administrative Management Needs for Value-Based Care. This is probably the most basic need for value-based care. Then in the second lecture for Unit 3, we'll look at how financial, administrative, and clinical data and processes need to converge. So in this lecture, we're going to review the basics of the HIPAA transactions and code sets and how they may or may not be used in value-based care. We'll look at what changes may be required to support value-based care. We're also going to look at revenue cycle management, which has been and will continue to be key to accurate and complete reimbursement, whether in fee-for-service or value-based care. The entire revenue cycle in most provider organizations is being looked at critically today to identify what improvements can be made to get better financial data as part of the value-based care equation. In physicians' offices, even with a management services organization contract, revenue cycle is often poorly managed. And in hospitals, there are many opportunities to better assure appropriate reimbursement. We are also going to take a look at clinical documentation improvement, both for hospitals and physician practices, as a means to ensure accurate coding and thereby accurate reimbursement, and, of course, to reduce the risk of potential fraud and abuse. Accurate and complete documentation and coding also contributes to improved quality measurement. Finally, we're going to address the need for more coordination throughout the cycle that manages revenue. So, HIPAA transactions and their standards from a provider perspective and health plan perspective, and really how they're coordinated between the two. We're going to start the discussion of revenue cycle management with a few slides devoted to looking at the HIPAA, that is the Health Insurance Portability and Accountability Act of 1996, administrative simplification transactions and their standards for use in administrative and financial processes. It must be noted that the electronic funds transfer standards were required later by the Affordable Care Act. HIPAA standards played a key role in moving healthcare to automation in general, and in fact, even in the incentives for electronic health records. HIPAA standards will have a significant impact on our ability to transition to value-based care in many ways. To start off, let's define what we mean by the term transaction. A transaction is an action of conducting business entailing the exchange of information and typically money. In healthcare prior to HIPAA, the process of filing a claim by a provider for reimbursement from a health plan was only just beginning to be performed electronically and not in a very standardized manner. In addition, there were other administrative and financial transactions associated with reimbursement that were even less standardized: the eligibility inquiry, prior authorization, claims attachment, claim status inquiry, payment and remittance advice. In addition, there were claims and other transactions which relied heavily on companion guides issued by health plans. There were literally thousands, as many health plans and health plan programs explaining what data each plan wanted and how it should be supplied for each of the transactions. Can you imagine when most physicians have contracts with 15, 20 plans, and hospitals potentially even more. How complicated that must have been. Regulations that grew out of HIPAA adopted the American National Standards Institute, ANSI, Accredited Standards Committee, ASC, X12 standards. And these are identified here on this slide by the number to which they are commonly referenced. For example, an eligibility inquiry is a 270 standard from ASC X12. A claim is the 837, again from ASC X12. We also want to note that sometimes these are called ANSI standards, which is really a misnomer because ANSI accredits standards organizations. It does not develop standards itself. ASC X12 creates standards for business processes in a variety of domains, including healthcare, but also insurance, supply chain, transportation, and other industries. In 1996, most business processes were performed by electronic data interchange. We call that EDI, wherein a document was transmitted from one computer to another. When these documents are not in a standard format, an EDI translator, that is in-house software or an EDI service provider, sometimes called a clearinghouse, is required to translate the format sent by the sender to the receiver. This is costly, time-consuming, and error-prone. To reduce this administrative burden, HIPAA mandated use of standard formats. However, even though the standards have been mandated and operating rules were added under the Affordable Care Act to make their processing even more standardized, with the exception of the claim, there is still a great deal of variability in adoption of the standards. Furthermore, newer web-based standards have yet to be adopted. This is largely because of legacy information systems in both health plans and providers that only process information in the point-to-point EDI exchange format, in contrast to web services using an extensible markup language or XML. Although many health plans have established websites to provide some of the information previously exchanged through telephone calls, paper mail, fax, and sometimes the ASC X12 standard, these are not as satisfactory as they could be. Providers complain that login and information supplied through these websites are not standardized, and any information to be saved from such websites requires manual porting. ASC X12 does offer a web-based standard called the Context Inspired Component Architecture, CICA, for building XML messages. And the Health Level 7, HL7, standards organization, whose standards are used in clinical information systems, offers financial administrative transactions support as well, which are used in Europe but nowhere else. Neither of these standards, CICA from ASC X12 or the HL7 financial standards, are federally mandated, so they're not used here in the United States. The administrative financial transactions required in revenue cycle management are typically used in the following sequence. First, a benefit sponsor, such as an employer, should enroll a person in a health plan and pay premiums using the enrollment and premium payment standards. I've said should because such employers are not covered entities under HIPAA, that is, they are not a provider, health plan, or healthcare clearinghouse required by HIPAA to use the standards. As such, most employers and health plans have alternative agreements on how transactions will be exchanged, but these are not standardized and do not work with the HIPAA standards. Information cannot flow from the health plan enrollment system directly into the eligibility inquiry and response system, resulting in the potential for eligibility information to be out of date if an employee is disenrolled or the employer doesn't pay a premium. A provider who checks eligibility, whether via the EDI transaction or health plan website, when a patient schedules an appointment or is admitted, assumes the information is correct and acts accordingly, perhaps only asking the patient for the copay amount used previously in an earlier visit or admission, or doesn't seek any payment up front, assuming the claim will be paid. When it is not, the provider must try to collect from the patient who is now out of work with trouble paying their bills. The second transaction is the eligibility inquiry. These are made when the patient has insurance coverage, but still can be problematic as the standard transaction offers minimal information on copay amounts, deductibles that may impact the current healthcare encounter, especially as people are opting for higher deductible health plans to save on premiums, and coinsurance, again leaving the provider to not fully understand the patient's financial situation. Once ascertaining that a patient has insurance, there may also need to be conducted a healthcare services review. This may be a prior authorization for a service before it is performed or a referral certification. If these reviews are not done or denied, the services may not be reimbursed. These services are often those that could be medically unnecessary or for a referral to a specialist who is out of a network of providers the health plan has approved. However, the ASCX 12278 standard for this is used less frequently than any of the other standards. In fact, 18% for prior authorization and only 7% for referral certification, whereas 97% of providers use the claim standard. With much of the process, this is conducted manually. The reason for the low rate of use is that there is frequently additional medical information required, and a claim attachment standard is the only standard in this set that has not yet been mandated under HIPAA. And this is because there is significant lack of agreement over which standard or set of standards to adopt, including standards for clinical document exchange from HL7 and the newer Fast Healthcare Interoperability Resources or FHIR standard from HL7 that provides an application programming interface that is not platform dependent. Again, legacy information system issues mean that provider EHR systems need to be updated to generate documents in HL7 formats or support FHIR. Health plans have never used any standards from HL7, so this is an even greater leap for them. The next step, now we're not really getting ahead of ourselves because a claim attachment in whatever format is used not only to supply additional information for a claim, which is next in our flow, but to provide additional information in support of a prior authorization or referral certification request before a service is provided and a claim filed. Today, most of these are paper, either mailed, faxed, or uploaded to a health plan website. So next is the claim. The claim standard, as I mentioned previously, is the most frequently used of these standards. 94% of all claims filed use the ASC X12 H37 claim standard. And this is because Medicare requires all claims to use the standard without exception, and a very large percentage of providers, hospitals, and physicians are Medicare providers. In general, providers only file paper claims when there is a coinsurance that must be coordinated. Though the claim standard accommodates coordination of benefits, COB as we call it, coinsurers often add requirements to the base standard that practice management and hospital billing systems do not and really should not have to accommodate, such as attestation of coinsurance being on the company's letterhead. Who does that anymore? Okay, so the sixth step is a provider is waiting for reimbursement. A claim status inquiry may be initiated to make sure the claim was received by the health plan, and if it is pending, for what purpose. Many states have prompt pay laws, so providers monitor that claims are not falling into a health plan black hole, so to speak. And is noted under the discussion of claim attachment for supplying additional information. Additional information may be necessary to support a claim. In many cases, providers know from previous experience that a claim for a certain procedure may require additional information and often send this information with the claim. This is called an unsolicited attachment. If there is no additional information supplied with the claim and some more information is needed by the health plan, the plan solicits additional information needed. It is very difficult to get accurate information on the extent to which either prior authorization or claims require additional information, but it is known that they present a huge burden for providers. It is actually a burden on health plans as well, but they continue the process as part of their due diligence to ensure their employer customers who are purchasing their insurance that they are doing everything they can to keep costs as low as possible. The final step, when health plans make payments on the claims, they send the provider a payment and remittance advice transaction, outlining what claims have been paid, how much has been paid for each claim, and supplying claims adjustment reason codes, we call these CARCs, and remittance advice reason codes, we call them RARCs. Plans do not necessarily pay claims in order of receipt, and they do not always pay the full amount of the claim due to previously negotiated discounts and other reasons. The intent of this standard is not only to provide this information back to the provider, but to work with a billing information system to post payments to the provider's accounts receivables. And of course also working with the banking information when payments are made via electronic funds transfer. Once again, legacy systems, especially in small provider settings where systems are often not upgraded in a timely manner, may not always post such information correctly or even not at all. To be complete in our discussion of HIPAA transactions, we must also look at the HIPAA code sets. These include administrative or non-medical codes and medical codes. There are quite a number of non-medical codes, ranging from the obvious zip codes to CARCs and RARCs we previously described. Some of these are universal and maintained by various organizations such as the U.S. Postal Service or the federal government such as the National Provider Identifier, Provider Taxonomy codes used to report the type or classification specialization of a healthcare provider, and the tax identification number. Other non-medical code sets are maintained by standards development organizations that create the underlying transaction standard. Medical code sets are those used for reporting a variety of medical information such as diagnoses, procedures, diagnostic tests, treatments, equipment and supplies, and drugs, biologics. A variety of medical code sets are used and are dependent upon who is using the codes. Hospitals, professionals, which are physicians, nurse practitioners, and others permitted to bill patients for services, dentists, and retail pharmacies. In addition to their use in determining medical necessity and other healthcare functions, medical codes are used to track public health. We'll look more closely at a variety of things relating to the transactions that may or may not support value-based care, but the shift to ICD-10 CM-PCS with its greater level of specificity has been a way to help the transition to value-based care. At issue, however, is that the transaction standards are essentially set in concrete, not able to be changed until federal regulation requires use of a new version or other standard or standards, as we had for adoption of I-10 and will be needed for when we move to I-11. However, there are some things that could improve. One is making sure that all applicable codes are recorded on the claim by the provider, and that the health plan accept and appropriately process all applicable codes. The claim standard has ample room for comprehensive description of the patient's condition and services rendered. Most hospitals do post all applicable codes, but most health plans truncate the number of codes accepted by their systems. Thankfully, medical code sets are updated generally annually, so new codes can be added that can support value-based care. For example, I could envision better description of episodes of care for bundled payment being accomplished through new code descriptions. So while the HIPAA transaction standards have not yet been fully adopted or even mandated, many are asking about their use in value-based care, as well as how any different or additional data may be exchanged between providers and health plans, although most hope for better, not additional data. Unfortunately, not a lot is known, but we can perhaps make some intelligent guesses. As noted, an important consideration is how likely changes will be made in the transactions. While ASC 12 does update standards periodically, not all versions have been or will be adopted. Since 2000, when the standards were first required to be used, there has been only one update mandated, and that required an extension due to the immense effort required by vendors and implementers. ASC 12 has developed additional versions post the version adopted in 2012, and many suspect these neither will be adopted. Since development of a new version and the lead time for implementation is long, and many changes can occur in the interim, it must be considered whether we even know enough today about what we will need 10 years from now to consider adopting another version. Furthermore, as administrations change in the federal government, proclivity towards regulation waxes and wanes. So what will happen? My guess is that transactions will not go away, but we are already seeing some changes in how they are used. First, the claim, which has always been available to use as an encounter form, is starting to be used much more for this purpose, thanks largely to Kaiser, which early lobbied against requiring them to exchange a claim within their organization. They did acknowledge, however, that the information was valuable for monitoring cost, and hence the use of the claim to document an encounter. Today, the claim as an encounter is being used in capitated environments. Also, despite complaints about accessing information via a health plan website, this is growing, incentivized by the fact that it can provide more and better information than what is available via the transaction. Though a bit extreme, I wonder if we could see the transactions falling by the wayside in lieu of web portal access. We are also seeing that many health plans receive diagnostic test results from commercial labs and also are being given access directly to certain portions of EHRs, often via health information exchange services. They are able to access what they need without a formal attachment transaction. Their limited access is documented and can be audited. Still, providers need health plan data on reimbursements to integrate with their clinical data so they can determine unit costs and perform other analytics, which we'll address further in the next lecture. They need access to claims data, what was reimbursed and what was not, and they need better data on medical necessity, narrow networks, and other factors that can reduce their reimbursement or put them at risk for loss. But they also need EHRs and billing systems, especially in hospitals and small practices, to fully integrate their data. There is nothing HIPAA, transactions, or privacy about this. Health plans need to be more transparent about what and why they need data and their reimbursement decision making. Providers need to be more prepared with data from their integrated EHR and billing systems to negotiate terms favorable to both providers and health plans. It may be necessary for professional associations and specialty societies to work on what is needed and lobby the vendor community for better interoperability, such as using blockchain.